Lalit Verma to speak on optimizing management of PDR.
I hope the video will work this time. You see, in the morning session or afternoon sessions, we had an overdose of diabetic macular edema. So I'll be talking something about other aspect of visual loss in diabetes, that is proliferative disease. Thank the organizers for giving me this chance. You see, diabetes, you all know, is increasing. Couple of months back, we used to talk of 77 million diabetics. Today, we are 101 million diabetics. And 11.4% of India's population is diabetic. Primarily because all of us eat more and exercise less. That is the whole reason diabetes is increasing, not only amongst general population, but even amongst physicians and ophthalmologists. So there are two things which we are bothered in diabetes. One is the moderate visual loss that happens because of DME. Then severe visual loss happens because of the sequelae of PDR. What everybody should remember is that it's a silent disease. So all of us, including comprehensive, general, posterior segment, every ophthalmologist has a morally bound duty to make people aware, not only patient but within their families and self also. Because it's a silent disease. Silent disease, all these patients have 6/6 vision. You see, even though this has NPDR, this is proliferative disease, but they all have 6/6 vision. Hence the role of seeking cooperation from public and even their relatives of regular checkup. As I said, moderate visual loss occurs because of maculopathy. Proliferative disease sequelae, either VH or PD or the TRD, that causes severe visual loss. So what I'm going to talk about the management, because companies are still pushing everybody to inject in every kind of disease. But I still believe that laser is the mainstay of PDR. Intravenous injections, भैया चाय वाय सर बंद कर दो. Intravenous injections still are not the main treatment in PDR. So please do not keep injecting in patients of proliferative diabetic retinopathy. So in PDR, thanks to DRS study long time back, we always do laser without delay, and even without HRC, that means even in mild PDR, at least I keep doing a full PRP. Not very tight, but we do a full PRP. Even in patients who have very severe NPDR, that means 4-to-1 rule or slightly beyond that, in the absence of PDR, we start lasering because these are the patients who will progress to PDR very fast. Even in patients whom we are subjecting to surgery, so wherever it is possible to laser, in the interim period, we can laser because lasered eyes during surgery behave much better than the non-lasered eyes. As I said, PRP has been the gold standard. It is not now. It is there for last more than 4 decades. And we have had patients whom we lasered 30 years back, still maintaining 6/6 vision. The confusion started arising primarily because of this protocol S study by DRCR-NET, when they started comparing PRP with the intravitreal pharmacotherapy in this study, and what was found was it is non-inferior to PRP. But remember, this treatment is required regularly. So I'll just share how I use injections in this patient of PDR. So here is an example, right eye of a patient. Macula is pretty good, but there are massive fronts, very big fronts, a lot of non-perfusion areas. So in such patients, I will inject, but always depend on laser. So did inject, you see this front did get shrunk, but depended ultimately on laser. So example, this is another example of a patient, again right eye. You see these fronts are very, very close to the macula, very close to the macula. If I laser here, it will, cause some ERM formation or some issues. So therefore, once the fronts are very close on the posterior pole, inject and then laser afterwards. So good scatter laser photocoagulation has saved many, many eyes for decades, and all of us have examples for this. Anti-VEGF, despite repeated injection, cost and visits, etc., have adjunct role only and should not be pushed irrespective of the pressure. Only indication could be if it's a very well lasered eye, Then again, there are some oozes, you can consider giving anti-VEGF injections. But believe me, early vitrectomy in these patients also go a long way because you remove the pull component, you remove the traction. So, couple of slides about the other component of PDR, where laser, will work, but after vitrectomy, where there have been sequelae. So again, all membranes do not require surgery. We were talking in the morning, all membranes do not require surgery. And patients who have TRD or vitreous hemorrhage and who have not been lasered should not be blindly injected anti-VEGF agents, especially in unlasered retinas. Again, this patient, who has traction but it is nasally and macula is pretty good, 6/12, hold your hand, believe me, diabetic retinopathies are not to be taken lightly. This patient who should be, given chance for surgery was injected with Avastin, but patient landed up in very severe kind of TRD. So do not go around injecting in PDR, especially with traction. So indications of vitreous surgery in diabetics are changing. No longer vitreous hemorrhage is the commonest indication. Commonest indication today is macular TRD. Macular TRD or a combined detachment is the most common indication in diabetic vitrectomy. So I'll just run through one or two videos. This is actually a vitreous hemorrhage, a simple looking surgery, but this lady presented with bilateral vitreous hemorrhage and could not walk. The culprit is this big, NVD here, which we trimmed. This, you should never do diathermy in such patients on the disc because it can transmit. So hold your hand. This surgery did not, last much. It was 10 minutes job because it was a total PVD. But what took more time was this laser photocoagulation. Disc macula are pretty healthy, and this patient has potential to gain back 6/6 vision. So these patients, I think, ultimately for long-term stability will require laser, and laser. So I spent 10 minutes in surgery, but 20 minutes in doing laser photocoagulation. And I'm very fond of doing laser in a proper row rather than tuck here and there, because I don't want to miss out any areas. So we did take 15-20 minutes to laser this eye, and ultimately this was the end of surgery. Does not require any gas injection, it just requires a simple airflow exchange. And this is the virtual end of surgery. This was the end result of this. So this was the other eye also of the same patient. So a couple of more videos about diabetic vitrectomy. This again is not a very difficult vitrectomy because the basic aim is to make a hole in the hyaloid, but do not forget this iatrogenic ooze which happens, do not leave for a very long time.
Lalit.
So this has to be taken care of. Sometimes once we are doing a diabetic vitrectomy, like in this patient, it may not be easy to take out a nasal membrane specifically because of non-maneuverability of the instrumentation. So in such patients, we do change the position of the microscope and your sitting chair, and then you can change this port, and then whatever was nasal now becomes inferior, and then you can do your membrane surgery very easily. So this is the last video which I'll share. This young lady, IDDM, severely proliferative disease and presented with combined detachment. So here again, finding hyaloid plane is a challenge. This, you see there's a hole here, and there's a massive proliferation here. So here just slight pull at the level of disc. Don't pull it till the lens surface, but slight pull so that your 25 gauge probe can go inside that, the plane. So once the plane is found, then you go in between the folds of the retina and do this membrane dissection, but be very slow, very gentle to the retina, and keep using various instrumentation to segmentation. Segmentation is the answer rather than pulling. And then once some segmentation was done, I injected PFCL in this patient just to see what else needs to be done. And what was required now was a bimanual surgery, where we did put this 25 gauge chandelier, and with the forceps in one hand and the scissors, curved scissors in the other hand, you remove these fibrovascular pegs which are being attached to the retina. And sometimes you can use this curved scissors to dissect also gently, like is shown here. but the advantage of bimanual is precision. So you do not create much complications once you are dissecting this bimanual. So this will come out without creating any break or without creating any bleeding in these patients.
Lalit,
Yeah.
time is
So
up.
bimanual surgery, it has a definite role in the management of DR, and I frequently resort to bimanual surgery. So this is the post-op of this young lady. So I'll just show a couple of pre-post photographs and conclude by saying that in this era, the visual results of diabetic complex vitrectomies have improved thanks to the new instrumentation, new machines, and pre-operative anti-VEGF which have become available and make the job much relatively simpler. But answer is work slowly. Patience is the key. Don't pull too much. And as I said, outcomes have definitely improved. Thank you very much.
तिवारी का change नहीं की.
Next is CSR.
Yeah. No. We
Yeah.
noted that. Lalit,
Yeah.
in the management between PRP and anti-VEGF agents,
Yeah.
especially protocol S,
Yeah.
because a lot of people are there in the audience, they will have a need to have a clarity. If you are committing for anti-VEGFs, what precautions would you take in these patients, PDRs?
In any case, Ajit, I am not advocating to do anti-VEGF
Anti-VEGFs
injections in
all
PDR.
cases. Yeah, okay.
In a non-laser, I will go ahead
Can
and
Dr. Neetu be ready for the other presentation here? Yeah. Tell me.
What I am saying is I am not advocating.
Yeah. Why?
Can you put on this slide? 1 second. Hello, slide.
No. Slides are not
No, it's
required.
okay. I'm not.
Slides are not required because she need to be ready with the
No,
presentation.
I'm answering that
Slides
question,
comes.
Ajit. What I'm saying is,
Yeah.
that in PDR, injections are not required. That's what I'm saying.
You don't want to advocate injections, or you
Only-
say one injection regress the new vessels
that I
only to
showed two
or
examples.
prevent the bleed. See, because protocol S has, because theoretically it has shown that multiple injections not only regresses the PDR but it saves the field of vision. It is very lucrative proposition they have come up with. But the downside of that is that if the patient do not come for follow-up, these cases can worsen like anything because the fibrosis will increase, the neovascularization, a rebound neovascularization which comes is very aggressive. So the cases can worsen. That's
So that
what
is
I
the
want to
reason, please.
advocate.
So, Ajit, that is the reason I'm not advocating at all. Because
Now
instead of passing on the blame to the patient, by India is a poor country, patient will not come for follow-up. Please do not advocate. If it is a laser retina, if there is some bleed, then you do it. But as a primary mode of treatment, if you start injecting just that front will regress, believe me, long term is not good at
Will
all.
not go.
Even
Will
in
not
US now, it is no longer considered a viable option at all for treatment.
Yeah. No.
There
Even
it was started in US, but even there it's not now understood that
So
laser has to be done.
Let us not advocate injections in a patient of PDR.
PDRs.
That's all.
Yes. One sentence is do not advocate. Second sentence I would like to extend is if there is a front which is likely to bleed in immediate future, because laser today you do, protection will come 2 months later or 6 weeks later. So temporarily you give the injection and do the laser, it will have a long-term beneficial effect. With this